Hello, I'm Jan Leifman.
I'm Gayatri Pramalmenan.
Welcome to Med News Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Lidia Schapira. Dr. Schapira is the Director of Cancer Survivorship at the Stanford Cancer Institute.
In today's presentation, Dr. Schapira discusses cancer survivorship and the psychosocial impact it makes.
Did you know that Dr. Schapira is an internationally renowned breast cancer specialist and cancer survivor global authority? She's a pioneer in communication skills for oncologists and designated initiatives to improve awareness for cancer research and clinical trials for underserved communities. She's also a recipient of the Fellow of American Society of Clinical Oncology and Cancer Care Inc.'s Physician of the Year.
She's truly a global leader in the field of oncology.
So let's tune in. Let's tune in and learn from this global pioneer.
What is cancer survivorship? So I'd like all of you to follow me as I think about how we can answer this question today. It is a question that is front and center for your cancer center leaders and administrators, for your patients, for patient advocates. So we're all in this together. So let's think about what we mean by cancer survivorship as a field of care, as a research topic, and as a matter for policy. So cancer survivorship focuses on the needs and experiences of any person living with, through, and beyond cancer. It starts with diagnosis and lasts a lifetime. We are increasingly expanding this definition, and you will see that it can be construed in different ways. For instance, for research purposes, perhaps a certain part of the survivorship experience can be addressed, the time after the end of active treatment, say with curative intent. But increasingly, we're also thinking about the needs of many survivors who live with cancer as a chronic illness, cancer that may not be cured, but is associated with longevity, such as, for instance, CLL. And now, in the last couple of years, there's also interest in including a category of people that we call meta survivors, those living with metastatic cancer, but who also have interest in participating in this collective effort to understand cancer survivorship. The origin of the term cancer survivor came from several decades ago, when there was a very moving essay in New England Journal published by a surgeon who was a cancer survivor and described the experience as something that really changes somebody forever. The research in cancer survivorship really also has been anchored mostly in the experience of children who survive cancer and become adults, so the adult survivor of childhood cancer, the adolescent and young adult survivors, and increasingly now a population of older survivors. So that's just to give you a little bit of context. At the moment, when we think about cancer survivorship, many people have construed it as the silver tsunami. As you see here in this graph, which you'll find in many review articles of cancer survivorship, the number is growing. In the US, it's about 18 million today, growing steadily. But you can also see here very clearly that the largest growing segment are the older survivors of cancer. So the silver tsunami is a term that refers to the fact that the population of cancer survivors is expanding and growing, but the majority, the bulk of it, will be increasingly made up of people who are older. And what does that mean? Well, it means that they come to us not only with cancer, but with comorbidities. So the simple model of thinking about caring for adult survivors of childhood cancer who were fine, except for their exposures to cancer therapy, is becoming more complex. And so is our thinking about how we're going to care for them. When we think about cancer survivors by cancer types, it's also important to see this. And this graph, I think this provides a very nice sort of pictorial view of the fact that the cancer survivors are distributed across many cancer types. Today in the US alone, we have over 3.5 million, close to 4 million breast cancer survivors. So you'll see the majority of research being done in that population. Also close second are prostate cancer survivors and colorectal cancer survivors. But there's a very significant number of survivors of gynecologic cancers, hematologic cancers, GU cancers, oral cavity, and new classes of survivors, diseases like melanoma and lung cancer that in the past were not associated with longevity or prolonged survival, but that has also changed. So the question for all of us is, who takes care of cancer survivors? And perhaps all of you carry an idea of how survivorship should be done in your head or based on experiences you've had or places where you work. And I want to challenge all of us to think a little bit about that. Survivorship 1.0, the first version of survivorship for adults, at least in the US, we can say started around 2005 or 6 with a publication of an Institute of Medicine book called From Cancer Patient to Cancer Survivor. And you'll still see that many survivorship programs sort of respond to the call from that initial document that talked about the need to define a workforce, define the scope of survivorship care, provide some level of coordination between the oncology sector and the primary care sector. And the thought at that point was, based on what was thought to be a good idea, but not necessarily evidence, that if a good care plan could be given to a patient and sent to the primary care, that would provide sort of the conduit and the connector between oncology care and primary care. So survivorship care plans emerged as perhaps the solution to what was really a complex problem that was exacerbated, and I don't need to tell any of you, practicing or receiving care by a very siloed medical care system. So the survivor care plans first were adapted from models of pediatric survivor care plans, but those models really depend on being very clear about the exposures to therapies, because it's the exposure to therapy, certain radiation fields, certain chemotherapy drugs. At the beginning, those were the two most common elements to treat cancer. And of course, our cancer therapies have now expanded. But the idea was that if you documented the age, the developmental age of the child or the young adult and the exposures, you could then map out what kind of surveillance studies they would need, both to monitor for return of cancer, but very importantly, for late effective cancer therapies. With adults, you may well imagine that the situation is quite different, but the idea was pretty much the same, that the survivorship clinics that were set up basically were to provide a communication intervention, a counseling intervention, identify problems, and provide the survivor care plan as the document to take from one sector to another. And this was strongly endorsed by healthcare practitioners and by advocates who participated in this report. The problem is that survivorship 1.0, which we'll say was 2005 to 2018, just didn't quite deliver. The programs were not built, really honoring all of the different aspects that were initially put into that, including advocacy, policy research, and so on. And this is very nicely summarized in a comment and controversy piece by Eva Grunfeld that was published in JCO a couple of years ago. Dr. Grunfeld is a Canadian health services researcher who has shown through brilliant work with many colleagues over many years that, for instance, one group of cancer survivors, women with early stage breast cancer, could be very well cared for in the primary care sector if there was good communication and a reasonable plan. She then experienced survivorship as a caregiver when her husband developed cancer, and that changed a little bit of how she saw the general need for care. And in this beautiful article, she lays it all out for us in the most thoughtful way. So how do we look after cancer survivors, and what do we mean by survivorship care? I've put here for you, again, one of the classic articles in this field that was penned by Lidia Schapira, who's in New York, and has been one of the very thoughtful contributors to establishing this field, and has served in many committees for professional societies. And in this piece in New England Journal, it's what I would think of as a call to action. It lays out the need for everybody, specialist and generalist, to become involved in the care of cancer survivors. And it defines different domains of care. And you'll see that these are similar to the ones that are defined by ASCO and by almost every society that has thought about this and sort of also form part of many of the guidelines. So what are the elements? What's the difference between, say, survivorship care in a longitudinal visit for a patient with cancer? Well, first, the elements are surveillance for recurrence of cancer, and that's something we do as oncologists for all our follow-up patients. It's risk assessment and reduction of problems through behavioral changes. For instance, as risk assessment and reduction through behavior would include taking history about smoking and exercise and so on, things that put us more in a health promotion area than what we typically think of as cancer follow-up. It involves an update of genetic risk, and we see many patients in cancer follow-up who did not have a proper genetic risk assessment, or perhaps were not referred to genetics because there was no time initially, because the patient wasn't ready, because something fell through the cracks. So the survivorship visits need to review the history and update the genetic testing. It includes screening for second primary cancers. And cancer survivors may, through inherited susceptibility to cancer, prior exposures to carcinogenic therapies or other host factors, also be at greater risk for second primary cancers. It includes assessment of long-term effects of cancer therapies. And we think of long-term effects, for instance, classically, chemotherapy-induced peripheral neuropathy, as those symptoms that start during active treatment and persist. And as any of you who have treated patients in the adjuvant setting with platinum drugs or taxanes, you know that chemotherapy-induced peripheral neuropathy is disabling and often persists for years and sometimes never remits. It improves but doesn't completely remit. Monitoring and education for late effective cancer therapies is different from long-term effects, and that late effects typically do not appear until years have passed since the original treatment. So drugs that have leukemogenic potential, for instance, that leukemia will not be manifest until years after the initial therapy. In some late effects, for instance, of radiation, such as fibrosis in particular organs, so on, may not develop until decades after the original exposure. So it's very important to know what these could be and monitor them. So we think of typically the anthracycline-induced cardiac toxicity, radiation-induced fibrosis in any part of the body as typical examples. Monitoring and educating for late effects. So the education piece is really important as well, and it needs to be done in such a way that we prepare people, we explain to them what we would be looking for, but we also don't scare them, since we know that that many of these late effects can actually be quite serious. The psychosocial function and support is really one of the key elements, and one perhaps that has been researched in the greatest depth. We know from anecdotal experience, from clinical practice, from research, that cancer can be a profoundly life-altering experience, and that some of the psychological problems associated with a diagnosis of cancer and being a cancer survivor just don't go away. and persist. Attention to body symptoms, the body scanning, sometimes being hypervigilant, being afraid of cancer recurrence. In fact, fear of cancer recurrence is across the board the most prevalent symptom among cancer survivors and can be quite disabling. It is different from generalized anxiety, although there may be some elements that they share, but it is something that, it is very important to assess and to address. And in fact, there are some evidence-based interventions to deal with that. And finally, care coordination between specialists in the cancer sector and primary care clinicians is also an essential element, and one that takes a lot of time, and one that many oncologists really aren't prepared or very interested in handling. And that's often something that is difficult. I mean, you probably all have had patients who've told you that they don't know who to call when they have a problem. Should they call their oncologist, their primary care physician, cardiologist? This is very difficult because not all patients have teams of generalists and specialists that talk to each other or even share medical records where they can look at this information. So how do we develop models of care? I'm sharing this diagram that was published in Lancet Oncology by Larissa Neckel-Udoff, Donnelly O'Malley, and Shauna Hudson some years ago. There were a series of articles that were excellent and very clear, published around 2017 as a package. And they had, very lovely theoretical models that imagined that care of cancer survivors could be delivered in different ways depending on the risk. So you can think about it, if we could develop a risk stratified approach and also employ the workforce so that people could get exactly what they need, not too much and not too little. So cancer survivorship absolutely depends on the integration of primary care. We can't do it without our colleagues in primary care. And so the models were those of shared care between, say, PCP and oncologist, and or more reliance on the PCP. Dr. Neckel-Udoff is a proponent, for instance, of an oncogeneralist model, where primary care physicians with specialty in cancer medicine practice independently and assume the care for many cancer survivors with specialized knowledge of this group. We can think of long-term follow-up clinics. We can think of integrating primary care physicians into our cancer teams. We can think of embedding cancer survivorship units in primary care practices, certainly in the academic sector, in university primary care practices. We can think of intervention-focused primary care. We can think of specialty clinics. We can think of employing lay workers or health coaches for health promotion for many populations. So, you can think of almost any way of delivering this whole bundle of care that includes elements of palliation for long-term symptoms, psychoeducation, which can be beautifully done by nurses, health coaches, even lay workers or advocates, specialty clinics, for instance, for sexual health or oncofertility or cardio-oncology. And then this large piece of health promotion, which has been shown actually in studies that is better done by primary care clinicians than by oncologists. So I've told you that a lot of the models that were initially constructed on this idea that if we could just build a good survivor care plan that was comprehensive and transmit that to primary care physicians or clinicians, then we could really provide a more seamless model of care. And that was what was used by accreditation bodies and insurers to sort of create standards for survivorship care. Well, that all sort of crashed a little bit when Dr. Jacobson led a study and initially presented his results at the 2018 Cancer Survivorship Symposium and later published them in JCO a few months later, where he did a systematic review of studies that had used survivor care plans and looked for hard outcomes of to determine whether or not they were really effective and couldn't find that. In other words, survivor care plans were appreciated and liked by many patients, but they couldn't really demonstrate that this very laborious work of creating these plans that you often heard took people more than an hour or so to complete actually improved hard health outcomes. So as a result of this, there's been sort of a redefinition. This is what I think of, as Dr. Grunfeld has said, as survivorship 2.0. As a result of this, there's far less emphasis on creating a plan as in providing survivorship consultation, which includes some communication aspects, some counseling, identification of problems, as I showed you, and providing also referrals for specialist services to address problems. So where are the gaps in survivorship care? Interesting that that is a question that is still being addressed through research. In the newest issue of JCO, you'll see the study, the mapping systematic reviews of breast cancer survivorship interventions using a network analysis technique that I really do not command, but I managed to read through this article. So there've been similar exercises and similar reviews published in the last year or two, mostly in psycho-oncology, but this one in the mainstream oncology journal and JCO, looking and trying to define whether or not there are gaps and trying to use those gaps as priorities for future research. So what they're looking at are studies that have looked at interventions aimed to improve survivorship outcomes and delivered in addition to cancer treatment. So if we think of survivorship care, I mean, I think what you're hearing me say here is that there's a special sauce that's a little different than just seeing patients longitudinally in a cancer setting, that we're thinking about their future health, that we're putting more effort on health promotion, that we're recognizing that for the large number of adult survivors of adult cancers, the cancers may be cured and they are quite likely going to die of comorbidities. And so we're trying to figure out exactly how the survivorship care can address all of these different aspects without necessarily creating more work in the cancer sector, and understanding what areas really belong in the shared care models between oncology care, specialty care, and primary care. So when you think of, or when you read about studies in survivorship, think about what outcomes you would look for, and think about what metrics you would use. And I've put here a few of them to guide you through understanding what survivorship models are looking for and doing. Most importantly, they've really focused on health-related quality of life and function, physical and emotional domains, healthcare utilization, ER use, hospitalizations, critical care, costs of care, both to the patient, survivor, and the healthcare system, and mortality, of course, all cause and cancer specific. So if we think about where the gaps are, and we think about how we can begin to close some of these gaps through strategic innovations in care delivery, I'm going to give you a few examples. One that has been talked about for a very long time, and we still haven't quite figured out, I think, certainly as a nation. Perhaps there are some institutions that do this very well, but we don't really have national standards, is risk stratified care. The idea being that somebody who has let's take somebody who's had a bone marrow transplant and has had complications of the transplant, requires very specialized care. And that is not nearly as the same as, say, a well woman who has a screen detected non-invasive breast cancer and never has exposure to chemotherapy, has an absolutely outstanding prognosis from her cancer, and hopefully will do very well. So not all cancer survivorship in adult is the same. And I think that most of the care needs to be risk stratified. But the problem is that we have not quite come up with very good algorithms that really match what people want and need. We do need those care plans. They provide sort of some safety for patients. They can be seen as treatment summaries with some recommendations for surveillance. They need to be guideline concordant, and they should be brief and customized. And if you think about what it is that the cancer survivor and the primary care doc need, that's what you should put up front. And some of the older versions of the survivor care plans actually had very extended staging and treatment categories that really did not interest the primary care sector very much, and often it didn't even reach the primary care docs. But when they did, they were not found to be very useful. There are more efforts to provide group education instead of one-on-one. This also allows us to conserve resources in the workforce. This is a wonderful platform for connection through social media, through other organizations as well, other ways of having peer-to-peer and survivors connecting with each other to share good information. There are disease-specific survivorship clinics that are embedded in clinical care programs in cancer centers. And that's sort of the model that our cancer center at Stanford is using. For instance, we have a breast survivorship clinic within the breast oncology practice. We have some special BMT survivorship visits at the end of treatment at day 100, so that they are provided by clinicians who also are part of the teams delivering care, are very familiar with the type of treatments people have had, and are good sources and resources of information as well. We have shared care models. This is ideal for nurses and APPs, advanced practice practitioners, nurse practitioners, physician assistants. They can be delivered by generalists or specialists, and they can include models for sharing care. And very important is the delivery, provision, and referral to supportive care services. Often survivorship gets lumped under supportive care. I would argue that it's not just supportive care, it's also a clinical service that sort of uses elements of cancer care and also primary care in terms of health promotion. But it's very important to have supportive care services delivered by other members, and these can range from education programs on communication within families, expressive writing, mindfulness interventions, all of these things that attend to the mental well-being. I would say that one of the perhaps most exciting areas of survivorship care that has not received sufficient attention in the US is this idea of personalized symptom management. In other words, empowering our cancer patients and survivors from the moment of diagnosis to begin to self-manage. And by self-manage, it means organizing their care, asking the questions they need, understanding where they can find sources of support, identifying those festering symptoms, being able to do things about them. And that could mean a referral, but it could also mean doing things that affect one's response. This is a wonderful area also, if we think about it, if we could only figure out exactly how to do it, to use more of the PROs and surveys, include them in the record, use them to customize and prioritize concern, and then perhaps refer patients to different sources for either behavioral or physical interventions with specialized help. So I have here two examples to give you an idea of where the field is at. The papers are a call to action that was published in JNCI by a group of us that call ourselves the Global Partners for Self-Management in Cancer. This is sort of a bit of a summary of where the field is at and many examples of how these kinds of interventions can be used. And on the other side is an example of some outstanding research by our colleagues in the Netherlands who have implemented this very smart system that they call OncoCompass. So patients are given a password by their oncologist and they enter the site. The site provides a lot of surveys and questions that help them identify areas that they may have difficulties with. This, of course, will depend on the type of cancer, the type of treatment, and the type of individual. And when you're administering these surveys, it may be very different 3 months after finishing treatment or 3 years later. But this site guides them to special customized education, exercises, and monitors their progress and tells them when they should actually alert a clinician as well. So this kind of thinking, I think, if we can think about digitizing interventions, if we can think about activating people to really think through some of their symptoms, I think holds great potential. So another important area in cardio is in cancer survivorship care is how we think of our specialists, and perhaps the discipline that is very well advanced, that has grown out of recognizing that there is a need, is cardio-oncology. I learned that there is now a journal of cardio-oncology. There is an annual meeting of cardio-oncology, or more than one, but there certainly is one that is also sponsored in the US by the American College of Cardiology that just met this year a couple of weeks ago. And if you look at what our colleagues in cardio-oncology are doing and what they're thinking about, it's really interesting that they have done and accomplished so much. So some of the thoughts that I wanted to share with you are that they're very interested also in this idea of proactive cardio-oncology. In other words, how can we prevent late cardiac complications of cancer therapies? And I have posed a question to all of you that in some cases we know what we're looking for, in others we don't. Many of the novel therapies that we're using these days, we are just learning how or if they potentially could affect the heart. And as you all know, who are doing great early phase clinical trials, we need to monitor very carefully and establish the parameters for potential cardiotoxicity. So the long-term follow-up guidelines, for instance, for the adult survivors of childhood cancer, which have been so beautifully outlined by the Children's Oncology Group, don't really help us when it comes to the 60 or 70-year-old who comes to your care, say, with CLL, who's already hypertensive, and you're now going to start ibrutinib. We need a better model. We need to understand when to share care, how to follow patients, especially patients who come to us already with cardiac comorbidities. And we need better algorithms to refer. I know that in our practice, for instance, we have a very low threshold for recommending a cardio-oncology consult for some of the women who already have other cardiac risk factors and had prior exposures. So as we think about advancing the field, we can think of active areas of research that improve these defined health outcomes. On the cancer side, all of us, I know, are working very hard to de-escalate cancer therapies. Anytime that you don't need to use chemotherapy or when you can avoid radiating, these are all potential long-term effects and late effects that you're preventing. So it's really important. Precision oncology, I sincerely hope, will allow us to further de-escalate, and perhaps eventually someday we'll also be able to think about the possible late effects and bring that conversation also into the initial decision making, so that depending on what somebody aspires to do in their life, we can minimize the toxicity of cancer therapy. It's really essential that we track long-term and late effects of novel therapies. And again, this is my plea to all of you who are designing new studies to think about this and do what you can to advance the knowledge. And I think it's really important to understand host effects in addition to mechanisms of toxicity. So the interplay between host, age, developmental age in the case of the young survivors of cancer, and the dose and the type of cancer therapy that's used. We can also affect the behavioral side. We may do everything we can to achieve the most effective, the best possible outcome in terms of curing or treating the cancer, but we also need to begin targeting behaviors. Wise interventions, I'm not just assigning wisdom to an interventions, is a name that has been given to short, targeted, effective behavioral interventions. And I'm just going to give you an example of one in the next slide. But this is a perfect field for targeting interventions. If you think about a lot of the work that's being done and published in the recent years with cancer survivors, a lot has to do with mindfulness interventions, interventions designed to improve cognitive function, to improve perhaps how confident people feel. So these are very important. We need early referrals to supportive services. The perfect example I can give you, I'm sure you'll agree, is fertility preservation, but perhaps we should think of other areas that could use early referrals before the problems really set in. One of them would be, for instance, intimacy and sexual health in men and women of all ages. We can think of co-management. And again, if you're going to start a patient who has cardiac factors on a potentially cardiac toxic drug, perhaps co-management is a way to go if you have the resources and you can do it. And then, of course, empowering patients. And this is where social connection can be really important, providing expert vetted information to patients and families and timely access to both primary care and specialty care. So now let me have a little fun and tell you about an RCT that we just finished. We're still looking at our results, so hang in there. Hopefully you'll get to see those soon. But our idea here was that watching so many cancer survivors live with so much fear led us to think that perhaps if we could just target the way they think about their bodies, the way they think about cancer, perhaps with a wise, meaning a short targeted intervention, we could affect that and make it better for them. So with colleagues in the psychology lab, my colleague Ali Crum and her graduate student Sean Zion and a bunch of other people, we designed a study, a two-armed parallel group, unblinded RCT. And we actually recruited during COVID. So this was quite a challenge. But the idea was here that, the study was 10 weeks from baseline to post-intervention, and these people were newly diagnosed. Our original idea before COVID was to do this in person with people getting adjuvant therapy. So that very early, fresh survivorship period when they're sort of transitioning from diagnosis to treatment with curative intent and then to survivorship. And we designed a series of films mostly narrated by other cancer survivors with some experts, a series of exercises that we delivered in a steady fashion during this period of the study. And as we're looking at our results, we're excited. This just to say that there may be other sorts of wise interventions or targeted interventions that we will be seeing reported and hopefully in the next few months and years, basically trying to catch our population of cancer patients and survivors earlier on, before they develop some ways of thinking about their body that could potentially be very difficult later on. So how do we advance the field and how do we create a community of professionals who are ready? Well, our group has designed a medical education course. It's fun. We did it with the team at the medical school, the education design team. It's free. We provide CME. We've tried to make it ridiculously easy for people to access it. And we've just come out with a textbook, again, with the idea of expanding the resources that people have so that we can grow the workforce without paying attention to discipline or specialty. I think everybody is going to be seeing more and more cancer survivors, and the better prepared they are, the better. So just to show you how we've designed the course, we have it's based around 4 cases, a young woman who's a Hodgkin lymphoma survivor. And here, what we're bringing out is the fear of cancer recurrence, her concerns about fertility and late cardiovascular effects. Our second case is Bob, who's a 61-year-old head and neck cancer survivor. And here we want to draw attention on the need for multidisciplinary specialized survivorship care, because there can be so many effects related to the local effects of therapy, including swallowing and eating problems, glandular problems, and of course also emotional problems as well. The third case is our postmenopausal breast cancer survivor who is on estrogen deprivation therapies. So we use that case as a way of providing some tips on communication, bringing awareness about sexual health problems that may result from endocrine therapies, and again, the fear of cancer recurrence. Since all of you who take care of cancer patients know that for many of our survivors, a headache is not just a simple headache, but in their mind, they may be thinking that this means that they have brain metastases, and they may call you and ask for either testing, reassurance, or advice. And finally, the case of Richard, our 74-year-old prostate cancer survivors. We cast Richard as a university professor who didn't know if he really wanted to be screened, finally agreed to be screened, was diagnosed and gets treated, and then suffers from many late effects, which really change the quality of his life. And he sort of has some doubts or even regrets about whether or not he should even have been treated in the first place. There are many other courses. The American Cancer Society and GW partnered and have a series of online modules as well, also designed mostly for primary care clinicians. Harvard has a course. Memorial Sloan Kettering offers a course. And again, what you'll see is that most of us really think that that we need to educate our colleagues in primary care. That's where the money is. And I'm calling your attention also to this upcoming international conference that will bring together many people who are doing very thoughtful clinical work, epidemiological work, and research. So some resources as I finish, there are guidelines. So if you want to provide guideline concordant care, take a look at these. They're very comprehensive. ESMO has guidelines as well, and they have a wonderful downloadable guide on survivorship, which is really very good. ASCO's cancer.net. As you may have heard, a couple of weeks ago, ACS and ASCO announced they were joining their patient education sites. Cancer.net provides expert vetted information. All of these sites are free of any commercial input, so they're absolutely wonderful to recommend. And as you see here, there's a tab on your landing page that takes you to survivorship materials. ASCO also has a cancer treatment and survivorship care plans that can be downloaded if you want to start a survivorship program and provide these for your patients. Both NCCN and ASCO have downloadable guides for your patients. And thinking about one of the most important topics that comes up over and over is how to tell the kids that a parent had cancer. And I would strongly recommend this wonderful book written by Drs. Rausch and Muriel. That is a classic. And they'll also look at their website. That can be very useful. So if you're building a cancer survivorship program, I would say that our new version is that we're no longer improvising, but we're now planning. What started out more as a grassroots effort of let's do this and let's think of good ideas is becoming more of a different kind of field now, where there are more questions asked about metrics, which are hard to find in survivorship care, workforce, who will deliver the care, and what are the elements that you need to put into a program. So I would say that what you need is a cadre of patient-facing programs. You need to provide education, you need to provide support, you need to provide connection. You need to have specialized, customized clinical services, and the examples that I gave you today, sexual health, for instance, psychological counseling, oncofertility are just 3. You need to provide or think of providing care coordination and build a network of primary care clinicians, and this has been challenging for many. Remember that PCPs are better than we are, and as oncologists at health promotion. Integrate survivorship planning, if you can, in your care plan from the beginning. So think about when specialized cancer services will end or how they will be continued without necessarily having patients sort of think they need to come to you forever, unless, of course, they have a specialized need or at very high risk. And we need to standardize the visits based on guidelines and best practices. And that is a challenge for all of us. So I thank you for your attention,